After having a tour to the different parts of respiratory tract, why not discuss the lungs as a whole? Also, I will discuss the different respiratory muscles involved in the process of respiration, and how does the respiration take place. So, stick to the video till the end. Now, the lungs are large, spongy, cone-shaped organs that fill the pleural cavity. They are enclosed within the thoracic cage, formed from the ribs, sternum, and vertebral column, with the dome-shaped diaphragm, separating the thorax from the abdomen. The right lung is comparatively larger in size than the left lung. But why is that so? What can be the possible reason? Well, left lung is smaller in size, giving room to the heart on the left side. This space is called cardiac notch, where heart fits in. Now, the bigger one, the right lung, has 3 lobes that can easily be seen here: the superior lobe, the middle lobe, and the inferior lobe. And it contains 2 fissures: horizontal fissure and oblique fissure. It handles 55% of the gas exchange. While the left one has only 2 lobes, an easy way to remember this can be L for left and L for less. So the left one has lesser number of lobes, the superior lobe and the inferior lobes. The medial surface, as I mentioned before, contains an indentation called the cardiac notch that accommodates the heart. To divide the lung into 2 lobes, it needs only 1 fissure, the oblique fissure. The left lung, smaller in size, manages to handle only 45% of gas exchange. Now, an interesting fact here is that the right lung is a more common site for inhaled foreign bodies. Why is the question? Well, this is again because right main stem bronchus is comparatively wider, more vertical, and shorter than the left. So, if you aspirate something, say peanut, then, while in supine position, it usually enters superior segment of right lower lobe, shown here in pink. But if you are lying on right side, it is more likely to enter right upper lobe, shown in blue. Whereas in the upright position, most probable part of entry is the right lower lobe, this highlighted one. Now, the primary bronchi, pulmonary blood vessels, and lymphatics all enter each lung through one door, an opening on the lung's medial surface called the hilum. Now, the lungs are covered by a thin serous membrane, visceral pleura, continuous with the parietal pleura that lines the entire thoracic cavity. The space between the visceral and parietal pleurae is called the pleural cavity, containing pleural fluid that serves 2 purposes. One of them is lubrication, because lubricating the pleural surfaces allows the 2 surfaces to glide painlessly against each other as the lungs expand and contract. Now, because pressure in the pleural cavity is lower than atmospheric pressure, it creates a pressure gradient that assists in lung inflation. I'll be explaining this a little bit later. Now, if you remember the very start of the video, where I mentioned 4 distinct processes of respiration, one of them was pulmonary ventilation, which is simply what you call breathing. So, it is the repetitive process of inhaling, called the inspiration, and exhaling, called expiration. Both actions depend on the function of respiratory muscles and a difference between the air pressure within the lungs and the air pressure outside the body. One inspiration and one expiration comprise one respiratory cycle. Now, there are 4 types of muscles that aid in breathing. Diaphragm, the most important one. It is a dome-shaped muscle separating the thoracic and abdominal cavities. External intercostal muscles, internal intercostal muscles, and some accessory muscles. So, let's see the magic they create. During inspiration, the external intercostal muscles contract, pull the ribs upward and outward widening the thoracic cavity. The internal intercostals relax and help elevate the ribs, while the diaphragm contracts, flattens, and drops, pressing the abdominal organs downward and enlarging the thoracic cavity, hence reducing the pressure. As a result, air rushes in to equalize pressure. In contrast, during expiration, opposite happens. The external intercostal muscles relax, pull the ribs downward and outward, while the internal intercostal muscles contract, pulling the ribs downward. The diaphragm relaxes, bulging upward and pressing against the base of the lungs, reducing the size of the thoracic cavity. And hence, air is pushed out of the lungs. Now, during times of forced or labored breathing, additional muscles, called accessory muscles of respiration, join in to assist with breathing. For example, during deep inspiration, muscles of the neck that are the sternocleidomastoids and scalenes, and the muscles of chest, the pectoralis minor, contract to help elevate the chest. During forced expiration, such as when singing or shouting, the muscles of the abdomen, rectus abdominis, and external abdominal obliques contract to pull down the lower ribs and sternum, as the internal intercostals pull the other ribs downward. This further reduces chest size to expel air more rapidly. Now, people having difficulty breathing may depend heavily on accessory muscles to breathe. For example, in emphysema, lungs lose elasticity, and exhaling is no longer a passive process. Here, patients must use accessory muscles to exhale, making exhaling an active, exhausting process. In other patients, the use of accessory muscles can indicate acute respiratory distress, signaling a medical emergency. Now, during inspiration, how are the lungs expanded? Now, the lungs expand along with the chest because of the two layers of the pleura. The parietal pleura, which is firmly attached to the ribs, and the visceral pleura covers the lungs. Although not attached to each other, the thin film of fluid between the two pleurae causes them to cling together like two pieces of wet paper. Furthermore, the potential space between the two pleurae, the pleural cavity, maintains a pressure slightly less than atmospheric pressure. So it has the negative pressure. This is what we call intrapleural pressure. When the ribs expand and the parietal pleura pulls away, intrapleural pressure becomes even more negative. This has a suction-like effect, causing the visceral pleura to cling even tighter to the parietal pleura. And so, the visceral pleura follows the parietal pleura, pulling the lung along with it. When the lungs expand, the volume of air in the lungs spreads throughout the enlarging space. This causes the pressure within the bronchi and alveoli, known as the intrapulmonic pressure, to drop. When intrapulmonic pressure drops lower than atmospheric pressure, air flows down the pressure gradient into the lungs. Now, what do you think can be a consequence of a punctured thoracic wall? Well, if the thoracic wall is punctured, air from the atmosphere will rush into the pleural cavity, transforming what is normally a potential space into a space filled with air. As a result, the negative pressure that characterizes the pleural cavity is lost, and the lung recoils and collapses. This is called a pneumothorax. Air can also enter the pleural space when a weakened or diseased alveoli ruptures. This causes a disruption in the visceral pleura, and air from the lung enters the pleural cavity, again resulting in a pneumothorax. I hope now you are much clearer about what's happening inside your body each time you breath in and breath out. But still we are left with another interesting part of the video, that is about the lung volumes, pressures, and lung capacities. So do not go anywhere and just click the next part to grasp all the concept.